I think we should start because Dane is occupied, as you can see, he's already in his surgical suit. So I start with the name of Almighty God, who is the most gracious and merciful. Good morning, good afternoon, or evening, wherever you are in the globe. You are all welcome. Salams and greetings to you all. I feel extremely honored and privileged to welcome you all to this sixth webinar program for the year 2023-2025. Before we start, as traditionally, we have a talk usually about DFU International, but today I have made it very brief because Dan has agreed to talk and he has to rush for a scheduled surgery. He's already 6 o'clock there in the morning and he's got a surgery at 7 there in States. So thank you, Dan, to agree. After Dan talks, we'll have announcement of the winner of the grant project, which is we'll talk later on 2024. Okay, I'm going to share my slides. So just briefly, activities during 2023-2025. All you are aware of this, was people who are new to it. We have a flagship program, and one of them is this webinar, and then train the foot healthcare professionals, and all these things, programs which has been going on in at the moment in DFU International in last 2 years. Then we have these newsletters coming every 3 months. The six of them have already been out, and seventh one would be end of this year, means this month in December. This is the webinars which we have every 3 months on Saturday between 2 to 3 p.m. Central European time. But today, because it was requested by Dan, so we made it at 1 o'clock. As I told you, he's busy. And already 5 of them, all renowned speakers, have already been done. And today is the 6th one where Dan is going to talk on the surgical aspect of diabetic foot ulcers, to be followed another 2, which will be on 8th of March next year and 7th of June next year. You can see it's JEP and SICOVAS. We have a 3rd International DFU International Conference and 8th Biannual Journal Assembly on 9th to 11th in Malaysia. You are all welcome. So book your calendar for that. It's an election year next year, where I'll hand over to my President-elect, Professor Hari Krishna. Today's webinar's registration, the last which we calculated at 12 noon Central Europe, was 280 delegates from 53 countries. And panelists, all board members, all regional chairs, regional advisory board, and we have a guest panelist as well. So one of them is here, Dr. Muhammad Wahid, who is a reconstructive plastic surgeon from Maldives. Is currently head of Department of the Surgery and Deputy Medical Director of Darumwantan Hospital, Maldives. He's an Executive Secretary of Maldives Association of Surgeons, and many other achievements. We have also other surgeons who are the members of DFU International, as Professor Sharkawi is there, Professor Milland is there, and Professor Roberto. All of them are there, and we all know them. And then these programs and many others are being sponsored by Urgo. So thank you very much, Urgo, for supporting us as always. And they were also very good in supporting Awareness Week, which we did it last November. Coming to our main speaker, Professor Dane, we feel extremely honored and privileged to introduce the speaker for this 6th webinar education program. Dane is a professor and chair of Department of Orthopaedic Surgeon at UT Southwestern. He is also a medical director of orthopedic surgery at UT Southwestern University Hospital. He is present a chairman of International Association of Diabetic Foot Surgeons, and we did a combination last September in Mumbai, combined meeting. He is a chairman of Charcot Foot subgroup of International Working Group Diabetic Foot for the year 2023 guidelines, which came in May. He completed his general surgery residence at orthopedic surgery residence at Walter Reed Army Medical Center, followed by fellowship in foot and ankle surgery at Cleveland Clinic Foundation. As an Army Medical Corps officer, Dr. Dane is served as a Chief of Orthopedic Surgery in Operation Desert Storm and Desert Shield. So he's an Army Journal. He's achieved a rank of Major okay, with U.S. Army receiving several Army Commendations medals and an Army Achievement Medal. Then also received Southwest Asian Service Medal and National Defense Service Ribbon. Dane is a nationally renowned foot and ankle specialist, educator, lecturer, and research. He serves as a peer review of renowned 11 journal and is an author or co-author of several book chapters dealing with foot and ankle problems in athletes and patients with diabetes. His research interest is mostly the complication of circular external fixation in patients with diabetes, foot and ankle problems in post-transplant patients, treatment of spastic deformities of foot and ankle in patients with traumatic brain injury and or stroke. He remains actively involved in education of orthopedic surgery, not only around the world, but also locally as orthopedic residents, with orthopedic residents. Dan is a board certified by American Board of Orthopedic Surgery, a member of numerous professional organizations, include American Academy of Orthopedic Surgeons, American Orthopedic Foot and Ankle Society, American Orthopedic Association, and American Diabetic Association. So we feel extremely honored and privileged to welcome our speaker, Professor Dane Wukich, for this sixth webinar program, Surgical Aspect of Diabetic Foot, International Working Group Diabetic, according to the 2023 guidelines. And all the questions can be posted on Q&A section during his talk, and we'll discuss later on. Thank you very much and welcome, Dan.
Thank you.
You can now share
my
the
screen.
slides. Yeah.
Okay. Let's see, make sure I get this right. How does that look? Does that look okay?
Yeah, perfect.
Okay, great. Well, thank you for the introduction. I'm humbled by being invited for this. Just advance this here. Okay, these are my disclosures. As you mentioned, a lot of the things that I've done. So when I think of diabetic foot ulcers, I think of really the ultimate thing that we're trying to prevent, and that is limb loss. And so it starts out with somebody with what appears to be a benign forefoot ulcer. They end up getting a transmetatarsal amputation. They go more proximal to back in the hindfoot, and eventually a below knee amputation. And when you look at this, we see that, these patients, when they end up with a below knee amputation, they don't usually go directly to a below knee amputation, but they start out with a foot or toe problem and it progresses proximally. So I think what I'm going to spend a lot of time today on is really the forefoot, because I think that's where the most common problems occur. So when I think of state of the art of diabetic foot ulcers, there was a book, it said it's simple, but not obvious. But really the key things of diabetic foot ulcers are things that we know about. We want to debride, we want to offload, and we want to use, appropriate wound management. And sometimes we get ahead of ourselves and try to do very sophisticated things when all that we need to do are these three simple steps. Okay, so keep that in mind. And I think probably the one that gets missed the most or not done as well is offloading. So what have I learned? I've learned that it may be simple. We debride the wound, we offload the wound, and we cover the wound. But I think one of the questions that we have to ask is, why did the wound occur? And so start at the beginning, we debride it, we offload, we cover the wound, and then you have to ask the question, once you get it healed or even before, why did it occur? Because every wound has a biomechanical reason for occurring. Here's two articles that I published because I became interested in this probably about 10 years ago, because I saw that my patients really were very afraid of losing a part of their body. And we published an article in 2017 where we looked at this and found that patients who had a diabetic foot problem actually feared losing their leg more than dying. It was a reasonable study, but methodologically it wasn't as good as I would like. So with the help of a biostatistician, we improved this and we republished a similar study, but much more in depth in 2022, and found that amputation and infection were the greatest fears in patients with diabetes who had foot complications, even more than dialysis, having a stroke, having a heart attack, or blindness. So the bottom line is that when you start out with somebody with a severe infection and you end up with an amputation like this, it's a real spectrum that we have to recognize. And the bottom line is our patients, when they come to see us, what they're really fearing at that point in time is losing their leg and becoming infected. There have been many studies out there that show that diabetic foot ulcers reduce our health quality of life. No question about that. This Dial study from 10 years ago showed that there was low health-related quality of life, major amputations. And so you look at this large study from 10 countries, and interestingly, they found that it wasn't related to ulcer healing, but more the ulcer itself. And so what happens is they get this low health-related quality of life, leads to a major amputation, death occurs, and again, not necessarily associated with healing per se. And we know that what we fear is that patients who lose their limb have survival that's not as good as people who have limb salvage. And you can look at these graphs over a 10-year period, and you can see that, this is a study from many years ago, but the survival of somebody with an above-knee amputation was less than 20% at 10 years, and a BK was about 1 in 5. And that trend continues. And so you look at another study where Wukich published this in Diabetes Care, again, probably about 20 years ago, and looked at a healed diabetic foot ulcer, and you can see that their 5-year mortality was 44%, or their survival was 56%, compared to an amputation, which was 47% mortality, or 53%. Not a whole lot of difference in these patients, whether they had an amputation or not. So for me, it always made me question whether it was the amputation or whether the amputation was a surrogate marker of how sick patients were. So if you look at somebody with peripheral artery disease, a healed diabetic foot ulcer, Charcot foot, or even amputation, and you look at 5-year survival, it's really not much different. So I'm a believer that it's not the amputation that's associated with it, but it's the reasons the patient had an amputation. Patients with amputations oftentimes have significant comorbidities. Obviously, they have usual neuropathy, but they may have severe peripheral artery disease. If you have severe peripheral artery disease, you're probably going to have significant coronary vascular disease and even heart failure, and potentially even renal failure. So it's really that comorbidities of cardiovascular disease and renal disease that result in the mortality in these patients. Now, Chris Attinger and his group looked at limb preservation and survival. And what they found is there was no difference in the rate of ambulation if people had a minor or major amputation, about 2/3 of patients. But they found that people who had a minor amputation had a higher survival rate at 2 years, almost double somebody with a below-knee amputation. And if you look at that at the surface, you say, wow, then if we save the foot, well, maybe they're going to live longer. Or you may look at this a little more deeply and say, well, the patients who required a below-knee amputation may have been sicker than the patients who were able to be salvaged with the foot. So a recap is that patients fear amputation and infection more than death. They have low self-reported quality of life. And that low quality of life is associated with having undergone major amputation and even with mortality. And so I believe in my heart that diabetes foot disease is a surrogate marker for underlying illness. And so that's it in a nutshell to get started. So I think we must change our thinking. That limb salvage is something that we always think about, saving the limb, but I think a better way to think about it is preserving limb function. To save a foot that's not functional is probably not good for somebody who may do much better with something like a prosthesis. And I recognize that getting a prosthesis is not easy for everybody. Socioeconomic status really makes a difference. And certainly in the United States, we have found that people who undergo major amputation tend to be from underrepresented minorities. In our population, Black people, Hispanic people, and Native Americans have higher rate of amputations than white people, even when you do propensity matching for these patients. And there are multiple reasons for that, but I think one of the reasons is access to care. So I think we have to really think about preserving our limb function for these patients. So if you save a limb, you save a life. It looks like people will live longer. So that's our highest priority, to save the foot if we can. And we know that a toe amputation is better than a partial foot amputation. And if we can avoid or reduce above ankle amputations, then we can really make people function better. Because if you have a foot that's functional, you don't need a prosthesis, your activity is going to be better, and you're going to be developing your heart muscle and continue to have cardiovascular function. So the highest ambulation level is going to be associated with, the foot amputation. And if you continue to ambulate, you're going to preserve your cardiovascular function. If you get a more proximal amputation, you may not have the energy reserve to be able to ambulate with a prosthesis. And that's certainly true for above knee amputations, where it's about 70% higher to ambulate. Below knee amputations is about 25%. And we did a study where we looked at our mortality was related to people ambulating after an amputation. Those who ambulated had a much better survival than those patients who did not ambulate. And I think it makes sense, because if you're sitting in a wheelchair or you're sitting in a chair and not exercising, you're probably going to have reduced cardiovascular preservation. So keep this in mind, save the foot, preserve that so you can have high likelihood of amputation and avoid the above ankle amputation, which we define as a major amputation. So you can see that this is a spectrum of problems here. This forefoot is really a problem. And we all know that neuropathy is really the key thing that starts this in motion. The lack of sensation, perhaps even the autonomic resulting in dryness of the skin, the motor neuropathy, as you see, most of these patients have clawing of the toes causing deformity. They get some form of trauma, they have the deformity, and what happens is they may even have ischemia. Not all ulcers have ischemia, but some do. But you put these things together, and that's the causal pathway for diabetic foot ulcers. So I always think of, we can't reverse neuropathy. We can probably have some input on ischemia, but we potentially can have some impact on deformity, and we may or may not be able to control trauma, although by getting shoes that fit, some of these ulcers you see here can be rectified. So what are the forces that cause wounds? The geometry of the wound tells you what forces are at work. There are two types of forces that we think of. There's a sagittal force and then a shear force. Shear force is, I think, one of those things that we see. I think anybody who doesn't have diabetes and neuropathy, who's an athlete that goes out and plays a new activity and comes home and sees a blister on their bottom of their foot, that's really the shear force. And these forces can act in the transverse plane or even the frontal plane. So peak pressure has been very well understood. There have definitely been things that show that we know we can map out where the high pressure areas of the foot. We understand that, we try and offload those. And so this is mostly in the sagittal plane when we're getting heel strike, midfoot stance, or even when we're doing toe off. That's where these forces occur. And it's really between the foot and the shoe and the ground. It's relatively easy to measure for people. And it's similar to what we call a ground reactive force. Shear, on the other hand, is less well understood. And that occurs in the transverse and the frontal plane. And that's actually between the bone and the plantar soft tissues. And between the soft tissue and the shoe and the ground. So there are two different interfaces. And so we have to, when we see this, we really have difficulty measuring shear compared to peak pressures. And think of it as friction, what causes blisters. And this is just an example of how friction would occur inside of our shoe. And that's exactly happens. Our shoe is not something that keeps our foot rigid. There is going to be motion in there. So peak plantar pressures, number of studies have been out there that show that these ulcers occur in certain areas, like you see under the first metatarsal head. And you look and you measure this and you can see, and by the red there, that's an area of pressure. There are ways that you can address that. You can address that with offloading with a good insert after you get the ulcer healed, but it may be necessary to do a surgical procedure to elevate that first metatarsal head by doing an osteotomy of the metatarsal. Sometimes you can do a tendon transfer that can help that. And it really is a very important area of treating diabetic foot ulcer patients to recognize that we can get these healed, but we want to prevent recurrence because I believe that it's about 70% chance of recurring. And you can see that when you have these pressure ulcers, they're really circular in nature. And you can see that on the left side, it's underneath the second and third metatarsal head, same there. And these are poorly pressure areas. And the illustration on the left, I think, is actually really important because it's something that I see all the time. When I do a hallux amputation or a ray resection, you get that incredible clawing or hammering of the second and third toe, and you plantar, metatarsal head is prominent, and you get these ulcers. Very, very common to see. I never used to do a lot of first ray resections for this reason, but now I do a lot of first ray resections, and I really see this thing and I anticipate it, and I try and do things prophylactically, whether it's straightening out the hammer toes and correcting them, or actually sometimes you have to do a metatarsal head excision. We do that in patients with rheumatoid arthritis all the time, and they do very well. But if you see a circular wound, you know that it's probably going to be from a focal pressure problem. Shear force, on the other hand, is going to look like this. The ulcer is a little bit less well-defined, and it can be very much like an oval or an oblong. It's elliptical, doesn't look nearly as well circumscribed. And the cause is you get rubbing, the classic blister formation that all of us would get with a new pair of shoes. And I think that's really the key thing, is I think sometimes it's just simply poor fitting shoes that leads to the trauma of developing a wound. That wound can become infected. And even I've seen this, and on my own pet, it's not even loose dressings, it's sometimes post-operative dressings that we make and we think that they're comfortable, but in certain areas, and the fifth metatarsal head laterally is one area, the anterior ankle is another, that we really have to be very careful when we apply dressings to patients. So when I think of surgical reconstruction, there's osseous reconstruction, and then there's tendon balancing. Osseous reconstruction can be as simple as removing a bone. It can be cutting the bone and realigning things, or it can be fusing the bone. Oftentimes, when you do an arthrodesis, you oftentimes do an osteotomy as well. And sometimes an osseous reconstruction can be a functional amputation. It may be prudent to remove a toe and allow you to get on with your life and get the ulcer healed than to try and salvage that toe. And generally, osseous reconstruction is usually done for sagittal force correction, but when you have rotational problems, like the foot is supinated or pronated, you might have some shear forces as well. Tendon balancing includes tendon lengthening, like the Achilles tendon lengthening. Sometimes we have to use tendon transfers, sometimes tendon releases. And so tendon balancing is really important in correcting sagittal force and also shear force. I really got interested in tendon rebalancing for diabetic foot patients because of the other interest that I have, and that is treating patients with traumatic brain injury and stroke who have deformities of their foot and ankle. We do a lot of tendon releases and tendon transfers. And then I started to put that together with my osteotomies to really allow me to correct this in the sagittal plane, the frontal plane, and the axial plane. So the goals when you reconstruct somebody is to remove or realign any bony prominence, whether it's in the forefoot, the midfoot, or the ulcer. And you want to achieve a stable and plantigrade foot. Sometimes, if you're not judicious, by removing a bone, you can take too much bone and make it unstable. You want to be able to wear a shoe or a brace. And the most important thing in my mind is to prevent a recurrence. And so if you look at this after a reconstruction, this relatively nasty ulcer, which is several centimeters in size, it's deep, has actually healed, and the patient is doing well with regard to that. And this was done by using osteotomies. Forefoot reconstruction is really something important to talk about because the overwhelming majority of problems are in the forefoot. You can do digital arthroplasties, which means correcting hammer toes. As you can see here, these patients have hammer toes, perhaps even claw toes from their motor imbalance. You can do treatment of their bunion. You can do an arthrodesis of their first hallux MTP joint. And then sometimes you can take out the metatarsal heads like we do in patients with rheumatoid arthritis. The patients in rheumatoid arthritis do very well with this operation, and our patients with diabetes also do very well with this. And in some cases, you have to do an amputation. So share a couple cases. 50-year-old gentleman, diabetes, 20 years like most of us see, obvious neuropathy. And this is a guy who needs a heart transplant because he has cardiomyopathy, he has renal disease, and he needs a renal transplant. So he's pretty unhealthy. Transplant team wanted his feet to be clear. I found that he had absent sensation, no vibration testing, and absent reflexes. The Michigan Neuropathy Index was really about an 8 out of 10, but he had normal pulses. And this is what his foot looked like at presentation. You can see the dryness, so clearly he has autonomic dysfunction. You can see that he's got hammer toes, he's got an ulcer under the fourth, he's got pre-ulcerative lesions elsewhere. And recognizing that I don't want to just get this healed, I want this to prevent recurrence because this guy needs both a heart transplant and a renal transplant. And once he gets transplanted, he's going to be immunosuppressed, so we want to make sure. And you can, over his fifth metatarsal head, you can see that he's got a shear ulcer, pre-ulcerative lesion laterally. So basically, this is involving all his metatarsal heads. So what I did is I borrowed my knowledge from treating patients with rheumatoid arthritis, and I simply went in there and took out his 4 lesser metatarsal heads. A pretty simple operation, relatively low morbidity because he had normal perfusion. And you can see he's got changes in his first, in his hallux, but I didn't have to do anything because that was not a problem. And 3 months later, his foot looks dramatically better. And now I can actually get him to the transplant team and he can get onto the transplant list. With this foot, he's going to function very, very well. Some could argue, should I have addressed the hallux? I could have, but that would have probably required me to offload him longer, and I wanted to get him to his transplant team. This is another patient, has that hallux ulcer that you see. Very, very common. This one has obviously got some infection with the redness and edema that you can see. Again, somebody near 60 years of age. The key thing is he has marked restriction of his hallux MTP joint. So every time that he steps, he can't dorsiflex his big toe, so he keeps jamming against the floor. It deviates a little bit. Again, normal pulses in this particular gentleman, absent sensation. And what you can see is he has severe arthritis of his hallux, and he has no motion. So every time that he tries to go into toe off, he can't dorsiflex his foot, so his proximal phalanx gets jammed against the floor. So this is what I do. I debride the ulcer, get down to healthy tissue. You see his range of motion is just very limited actively, but his ulcer is healing. We can get it to heal. Well, can we get it to recur, prevent it to recur? And again, his passive range of motion is virtually no dorsiflexion. And so what I did is a simple procedure, Keller resection arthroplasty, by just resecting a small part of the base of the proximal phalanx to allow me to dorsiflex. And as you can see intraoperatively, I have about 45 degrees of dorsiflexion intraoperatively, and before surgery, he had none. And that's what it looks like. And so postoperatively, you can see his ulcer is completely healed, and he now has some motion, so he's going to prevent that recurrence in all likelihood. So when I recap this, I think that all of you are great experts on wound healing, foot ulcers, but I think that what we all have to concern is it's not enough to get the ulcer to heal. You have to ask, why did the ulcer occur? I think if we don't address biomechanical abnormalities and understand the importance of peak pressure and shear, that we're going to have recurrences. So we have to think of this patient in multi-dimensions, the sagittal plane, the frontal plane, as well as the axial and coronal planes. And so this philosopher from the 6th century BC, Lao Tzu, always said that a journey of 1,000 miles begins with a single step. So you have to look and take this in process, get the ulcer healed, then figure out what you're going to do to prevent recurrence. I think that diabetic foot treatment is still taking baby steps, although we've come a long way in many years. We understand the importance of vascular disease. We understand some prevention. And I think really people do a wonderful job with prevention. But I think it's not enough. We have to think about addressing the biomechanics if we can. And I think that I liken it like my granddaughter, little girl at 3 months, started to play a little golf when she almost hit 2. And now she's riding a horse and doing very, very well. As her grandfather, who's an orthopedic surgeon, I get nervous about riding horses, but I think she's taking those baby steps. And now she's 8 years old and actually competing in horse racing. So, but thank you. That's all I have today, and I'd be happy to take any questions.
Thank you very much, Dan. Thank you so much. Very clear, sweet, and to the point. It was very focused and clear message. I know that time is not in our favor, so I will now open for discussion for the next 10 to 15 minutes, as all the surgeons are already there. As I mentioned before, Dan has to go, and it's already 6:30 there in the morning. So, Professor Shakavi, your hand is up. Okay, you can start. Thank you. Can you unmute it? Unmute.
Thank you very much, sir, for the wonderful presentation. Really very nice knowledge and experience that I understood. But as regard the ulcers recurrence in the plantar surface of the foot and on the side of the big toe, I had a lot of these patients before. But with the plastic surgeon in my team, we did 2 things: more debulking of the bone, residual bone, and also maybe release incision to have redundant skin, not to be under tension. This really relieved the headache of having recurrence in the ulcer. The third point is the shoemaker. We know him, and we give him instructions so that there is no any pressure over this area. What do you think for that? Debulking more of the bone and to make release incision to the skin so that it will never be on tension.
Well, thank you, and greetings from Cairo. You're in Cairo, I remember, right?
Yes,
yeah.
Sir.
And you're a vascular surgeon by training, right?
Yes.
So I think it's wonderful that what you bring up is having a plastic surgeon that's interested in this. I think one of the hard parts for all of us, not so much I have the same thing, but getting plastic surgeons to help with diabetic foot is not an easy job. You know, it's not sexy, so to speak, in the United States. So I applaud you. And I think being able to work with your shoemaker is
Yes.
such an important thing. And you bring up great things. I think any technique where you can reduce pressure by taking redundant skin, like you're talking about, and even the bone, those are so important. So you bring up great things that I would love to employ. And I think, in a talk like this, you can't talk. So it's great. And I think having a vascular surgeon working together with a plastic surgeon working with a shoemaker is probably something that is ideal. So I applaud you and thank you. Shukran.
Thank you very
Thank
much.
you. Thank you very much. There is a hand from Professor Millen, and I think then, as Dan, you mentioned about plastic surgeon, we have a plastic surgeon in the panelist, so he can comment after Millen has asked. And okay, Millen, your hand is there for a long time. You can start, and then Muhammad Wahid can come. Dr. Muhammad Wahid, yeah.
Good evening to all of you, and a very precise lecture, Dr. Dane, and thank you for that. So, we had a lecture by Dr. Francis last time, Fran, and I had mentioned that time that we should have this deformity correction as one of the guidelines in the IWGDF, because that is one thing which happens without the patient noticing, and the first patient goes to the physician. So if there is a reference from the physician for deformity correction, many patients would have a biomechanical correction, and the shear force and the gravitational force acting on the foot would be decreased, and I think we'll get less and less of patient having ulcers with this small correction. What is your view, Professor?
Well, I work closely with Fran, and if anybody could make it part of the guidelines, it would be Fran. And you're going to have Yop on too, and Yop is another one. So I think you have the key opinion leaders in the world, and Fran is a expert on wound healing, diabetology, and all this. So I think if you have somebody like Fran advocating for deformity correction and biomechanical correction, I think that's a win. And absolutely right, because I think the numbers are about 70% that we can get the wounds healed, but we want to keep them from recurring. So you're absolutely right that addressing this, and I think it's educating people. I don't think you need to be an orthopedic surgeon to be able to do a lot of the things that I talked about. You need to be a surgeon who understands biomechanics. That I was in India 6-8 weeks ago.
Yes.
The best biomechanical lecture I've ever heard was from a young plastic surgeon from Ganga Hospital. He did, I think his name was Dr. Madhu.
Madhu Swami.
And he worked for Raj. It was the best biomechanical lecture I've ever heard. And he's a plastic surgeon, and I was just blown away. So I think the more we get people thinking about this from different surgical specialties, when you're a vascular surgeon, plastic surgeon, non-surgeon, and you're thinking about biomechanics, then this talk today was worth everything that we've all put into coming together if we can educate people. So thank you for that comment.
Thank you, then. Fem, I'll come to you. Let's hear from Muhammad Wahid, and then I'll come back and you can put the comments. Yes, Dr. Muhammad Wahid is a plastic surgeon from Maldives. He's the only one in that country. Yes, you're welcome.
Hi, thank you very much, and good evening from here, from the Maldives. Well, I also believe that the biomechanics is the basics of correcting the deformities. Because as a plastic surgeon, we do a lot of tissue transfer, a lot of flaps. However, if the biomechanics is not corrected, the end result is not going to be very favorable. That's from my experience. And the other thing is that we let, after correction of the biomechanics, we let the wound to have a very good granulation. And then after that, we do some reconstruction procedures, such as either skin graft or flap.
Well, you bring up a wonderful point, if I could add. Technically, plastic surgery has evolved into the 2024 where you can do things with microvascular anastomosis that are just incredible. But you're right, if you reconstruct something and put a fasciocutaneous flap, a muscle flap, or a local rearrange, and you don't correct the biomechanics, it's going to fail. And
Yes,
that's
of
the
course.
part that I applaud you for being on the front edge of this, because you understand that. Some people, oh, I've got the wound covered and it looks great. But if you don't do that and work, if you understand it, you can take care of it. If you don't, you work with somebody. So you're absolutely right. And I'm always amazed at the technical skills of my plastic surgeons nowadays. They can do things that are just incredible, and you're gifted. But I think the fact that you understand and appreciate biomechanics, that unless I would say that you probably don't do those types of procedures unless you correct the biomechanics, because it's going to fail.
Yes, of course.
Thank you, then. Thank you, Mohammed. Let's go to Fran. Your hand is up.
Thank you. Yeah, it's really to continue the discussion, about correcting the biomechanics in the International Working Group of the Diabetic Foot Guidelines, and it is included in there. So the basics of wound healing are doing the basics first, offloading, revascularization, treatment of infection. And within offloading in the 2023 guidelines was included surgical offloading. And so that it was included with osteotomy and tenotomies. I'm really hopeful in the 2027 guidelines, we've got more evidence, more trials, which actually look at tenotomies and soft tissue management for offloading in a little bit more detail. But it was there, it was included in offloading and prevention. We just hope that there's a little bit more evidence on which to base it. So you'll just have to come to the 2027 guidelines release to see what's changed in this field.
Thank you, Fran. That's fantastic.
Thanks,
Thank you very much, Fran. Okay, Professor Sharkawi, I see your hand is again up. You can ask. You are muted. No, we can't hear you. You are muted. Unmuted.
Yes, I'm sorry. I want just to speak about the biomechanics, how to correct it. Really, during 40 years, I'm trying to correct. It's uncorrectable. You just try not to be worse and to deal with the present pathology to avoid ulceration or stimulation of amputation. But to correct the biomechanics, I hope we can do that, but in the near future, I don't think.
Well, you bring up a good point, and I think all of us would agree that prevention is much better than any form of treatment that we can get. You and I, as surgeons, I would say, Professor, that the best operation that I do is the one that I never have to do. And I think, but there are certain things that I think recognizing if they have an Achilles may be simple as working with your shoemaker in Egypt to create an extra depth shoe so that they don't rub against it. Does everybody need surgery? No, but I think we have to be cognizant of it. And our treatment sometimes doesn't mean that it needs surgery, but at least you have to think about it. So thank you for the comment.
Okay, Milan. Yeah. Thank you, then. Thank you. Yes, Milan.
So I heard the comment of Dr. Sharkawi, and he's right. But what we are trying to do here is not to correct the entire biomechanics. We are trying to help the wound to heal by correcting the biomechanics to a certain extent. And we should all know that the diabetic foot is never cured. It is always restricted. And whatever Professor Dane said was you should also teach the person how to change his gait, train him how to walk after the diabetic foot ulcer has occurred. So that this 2-3 things together would restrict the diabetic foot and help the patient to live a very good life on his own terms. That is what
I would agree with you. And, I think Fran would echo this too, that on the guidelines, we often we don't use the word cure, we use remission, so to speak. That that ulcer is in remission. It's almost like cancer. You're not cured, you're in remission. Charcot's in remission. That ulcer's in remission. I think if we think like that, then that will help us. And I think you bring up a wonderful point. Thank you.
Thank you then. Professor Shakari, the last question.
Okay, last
Dane
comment.
has to go. Yeah.
I think biomechanics in diabetic patient foot always is changing because the deformity always is changing upon new glide in the joint, new fracture, new modulation. So it's changeable. All the time is changeable. So as Professor said, we have to save the limb as much as we can and to leave the ulcer, no recurrence for that. Thank you.
So if I would close, I just want to wish everybody not only a great end to 2024, but a wonderful beginning to 2025. And if I could say this, I wish for everybody that we have peace on earth and take care of everybody. And in the United States, we're not allowed to say certain happy holidays or this and that. So I'm going to just say to all of you, may you find peace at the end of this year, and may next year be a peaceful year for all of us.
Thank you very much, Dan. Thank you. Before I hand over to our president-elect
I'm going to take off. Okay.
He's giving you a vote of thanks.
Okay. All right. Go ahead. I'll wait.
Yeah, Harry is finishing with vote of thanks, and then you can take off.
Okay,
and then Harry
fine.
will announce the winner. You don't have to.
I'm like a bride at a wedding. The operation can't start till I get there.
Yes, Harry, it's all yours.
Thanks, Abbas. I think I would like to thank Professor Dane Wukich for actually giving this session at 6 o'clock in the morning. It is but a 7. So thank you very much for your support and all that to actually give us on this. And it's actually one of the main things of DFU International to actually always spearhead education as part of our aim to prevent avoidable amputations. I would also take this opportunity to thank all our regional chairs, our regional advisors, our board, and also all the members of DFU International, as well as Ortho Foundation, and all delegates who have been actively being with us. So thank you very much. And I think, Dane, thank you. I think you can have fun at OT today. It'll be a good day. Have a good day on Saturday, at least.
Harry, I wish I had your background there. I kind of wish I were where your background is right now.
Yeah.
All right. Thanks, everybody.
Okay, Dan. Thank you.
Bye-bye.
Bye. Okay, Harry, you can carry on doing the announcement for the winner of the grant project. So it's all yours.
Okay, thank you very much. I think this past few months we've been having program or a project basically from DFU International, basically a grant for underdeveloped and also low-income countries and middle-income countries to actually come up with a project to a more of a clinical project to actually basically try to prevent amputation and all that for diabetic foot cases over the regions. Now myself, Fran, and also Abbas were also involved together with the team of the people who actually gave the grants and all that. And the whole meeting actually went through. And after getting about 13 of this applications and all that, we actually got a winner from the grant committee itself. Now, interestingly, basically, the winner of this session is actually from Dr. R.D. Wildan, who is actually coming from Indonesia. He's actually an endocrinologist working at the Faculty of Medicine, Universitas Indonesia. Now, it's basically based in Jakarta and Java, and this is the main national referral center in Indonesia. And he's one of the medical staff in the diabetes care in Cipto Mongopso National General Hospital and Secretary of National Diabetes Proctorship Program. Now, this particular group is also affiliated to one of our own national representatives, which is Dr. M. Yunair. So Professor Yunair is actually a very close friend and also in charge basically with our Western Pacific region. And the project proposal was actually bridging the gap on diabetic foot care education in Indonesia rural area. So it's a comparative study on online versus offline teaching methods. So this is his thing to how we can help to compare between doing this online work and also offline. And you can see, like for us also, basically, we are doing a lot of online webinars now that, plus our train the food trainer, and it's actually basically physically done. And this is actually good to bridge the gap with this education. And Indonesia is an archipelago of many, many countries. And there's about 300 million people in the whole area. It is coming up fast, and diabetes is quite high in that country itself. So this is actually a good proposal to look at. And we hope to actually start sending off the grant in time for him to begin his work by looking at the milestones, the variables. And at the same time, I would like to take this opportunity to thank Dr. R.D. Wildan for a job well done, or at least a proposal well done. And the thing is, we hope to see over the next 1.5 to 2 years how this actually affects the diabetic foot care management in Indonesia. Thank you.
Thank you very much, Harry. I think now we also know the winner of the grant, and it will be starting next year. That's what was being said. So thank you very much. Now, before I finish, I would like to mention that we will see you again on 8th of March 2025. There is a webinar by Dr. Jeff Wen on very important topic, and especially for low and middle income prevention of foot ulcers in person with diabetes. In the end, thank you very much to every one of you. Thank you, all of you who have attended it. Thank you very much.
Thank you all of you.